Good afternoon. My name is Louise Chaquette, and I'm a bilingual health promotion consultant for Health Nexus. Welcome to the webinar, Fetal Alcohol Spectrum Disorder and the Role of Early Childhood Educators in the Prevention of FASD. I'd like to begin by acknowledging Indigenous people who've been living and working on the lands across Canada for thousands of years, including the land from where you're probably watching this webinar today. We're grateful to have the opportunity to work in this territory. As you can see, all the participants are in listen-only mode, but you can post questions in the chat box. Today's webinar actually includes two presentations. The main presentation will be by Mary Mueller and Karen Huber. We will have a question and answer period right after that. I will then be wrapping up with a short presentation on Best Start Services. You can download a copy of the slides from the webinar platform, and a recording will also be sent to you after the webinar. As indicated on the screen, a short video will be shown. At that time, the sound will be coming from your computer speakers, not through your phone, so you might want to have those on. So out of curiosity, it's always nice to know what organizations people are representing, what sector they're from. So if you could answer the poll. Okay, and I can see people are starting to answer, so that's great. We'll see if we can put it up after, put the results up. I know last time we had a little bit of an issue trying to put up the poll right after, so we'll see. So far, we have 60% of people from daycare, early on centers, parent-child program. That is varying a little bit, so that's great. I'll see if I can actually show the results. I will see if I can show the results. Let's see here, and I think you can see the results at the end. A little bit different from the previous platform that we were using. So now I will change the presenter to Mary and Karen, and I will introduce them to you. So we have to turn that off, change the presenter, and very, very shortly we will have Mary and Karen as presenters. So Mary Mueller is a retired public health nurse from the region of Waterloo Public Health and Emergency Services, where she worked for 31 years, 20 of which she spent in the prevention of FASD. Mary's been the recipient of the Political Action Award with the Registered Nurses Association of Ontario for her work in FASD, and the Woman of the Year Award in Waterloo Region for her work in FASD and volunteering in her community. Wow. Karen Huber is the FASD Coordinator at the Developmental Services Resource Centre of Waterloo Region. She's been supporting children, youth, and families in the area of children's mental health for the past 25 years. For the past 10 years, she's been working to build supports and understanding for individuals with fetal alcohol spectrum disorder. She's been coordinating the Waterloo Region FASD Diagnostic Clinic, chairing the Waterloo Region FASD Action Group, and advocating provincially through FASD ONE for increased identification and support of the disability. Wow, you're in good hands. So I will, if we could see your presentation, then we'll be ready to go. Thank you. I'll give them the microphone.
Can you see our screen now?
Yes, we can. Thank you very much, Mary.
Oh, excellent. So thanks for having us. So I'm Karen Huber, and beside me is Mary, if you were wondering. What I'm going to start with today is just reviewing the objectives with you. So we hope after today that you're going to have a better understanding of fetal alcohol spectrum disorder, and that potentially you'll be able to identify some of the common signs and symptoms of FASD. And we hope that you will understand the incidence and prevalence and how that can be reduced through your work. And then, of course, we'll be able to identify strategies to reduce the incidence of FASD with parents, with the children that are in your care, and of course, within the larger community.
I'd like to encourage everyone too to put questions or comments in the chat box. It's much more fun for us to see what you're thinking as we're going along, and we'll either try and address that at the end, or we'll chat as we go along. So we want to make it a bit more interactive today. So Go ahead, type away.
Okay, so first we're going to start with our common understanding and definition of FASD. And we have adopted this definition of FASD through the CAN FASD Research Network. So it's important to understand that it's a diagnostic term, it's a medical term, a medical diagnosis that's used to describe the impact on the brain and the body, because we know more now about how alcohol doesn't just impact an individual's brain, but it actually impacts the entire body, and it's important to recognize that piece. It's a lifelong disability, and individuals with FASD may experience challenges in all of the following things: their daily living, their need support with motor skills, physical health, learning, memory, attention, emotion regulation, and social skills. And as you can understand, that is really all encompassing of an individual's functioning. So it's important to support all those pieces.
We are trying really hard to use this diagnosis. Definition, sorry. It has taken a long time for people to think about the specific language that they use in this. And we're really trying hard to use that language to reduce stigma, but also to have the same language when we're talking about anything related to FASD, so that we're giving consistent messages to the public.
Mm-hmm. And I think the last part of that definition that's really important is that it's important to focus on the areas of strength. So talking about prevalence, how many kids or families are living with FASD in our community? So the government, the Public Health Agency of Canada had recognized that 1% of the Canadian population lives with FASD, but we know now that it's much higher. CAN FASD is now saying the incidence is at 4%. And because the Public Health Agency of Canada had estimated at 1%, we know that there is a number of people that are undiagnosed with FASD. So we know that number is much higher than the 4%.
And it's hard to know exactly what percentage to use because the studies keep changing. So I think we just need to keep a watch on that and be aware that really we're looking at 2 to 4% currently. CAN FASD is a research network for Canada, and so they're continually studying that. So we just keep watching the percentages that people are quoting, but we do know it's not 1% anymore.
Mm-hmm. And this is an infographic that I like to use when I'm talking about the prevalence rates of FASD. It's sort of important to think about how it contrasts with some of the other disabilities. And at this point in time, with that 4% prevalence rate, we are understanding that it's 2.5 times more common than autism. And I think people find that very, very surprising. I know I did when I first heard that 4% number too. So it's just something to take a look at there, how it's much more common than some of the things that actually get much more support in the community than FASD does.
I'll talk a little bit about why the prevalence is so high. So we know in Ontario, past year alcohol consumption for women was 76.8%. So 77% of women drank in 2017. And 11.9% of those reported that they were exceeding the low-risk alcohol drinking guidelines. And I will talk about those a little bit later, but they're basically guidelines that have been created to keep people drinking at a rate that's going to reduce the risk. And for women in 2017, so 11.9% of women exceeded that. That's quite high, 12% of women. Daily drinking rates for women have definitely increased from 2001 to 2017. 2.6% of women were drinking every day in 2001, and 2017 we're now at 6.8. So that's a pretty concerning number, but that would give us an idea of perhaps why the prevalence is getting higher. Hazardous and harmful drinking for women increased from 4.8% in 1998 to 9% in 2017. So this is drinking that's doing harm to their health and their safety, and that's through something called an alcohol use disorder identification test. Most people would know it as an audit. And we do know that binge drinking rates for young women increased in the last decade. Recently, we saw a bit of a decline, and it's kind of bopping up and down, but we do know on the whole that binge drinking is one of the biggest concerns in young women, and binge is usually 4 drinks at a time in a close period of time. So most indicators increase as women's education increases, which is different than other substance use. We often will see that as education is lower, there's more substance use in that group, but for alcohol, it's much different. We know that as women become more educated, that their alcohol increase rises. So it's a little bit different that way. And we want to think about, well, are pregnancies planned? And I'm sure most women watching this will know that they aren't usually, but they can be. Public Health Agency of Canada states the rate of unplanned pregnancy in Canada is about 50%. So half of our pregnancies happen when people aren't planning for them to happen, which means that people may be drinking when they didn't intend to be drinking in pregnancy. The Society of Obstetricians and Gynecologists of Canada are currently in the middle of a study. It's not published yet, but they're finding the rate to be closer to 60%. So again, that certainly fits from my experience in working with pregnant women, that 50 to 60% are not always precisely planned. I think people are planning to have a child, but maybe not at that point in time, which they might be drinking while they're pregnant because they didn't know they were pregnant. If women are drinking more and unplanned pregnancies are high, of course, we would expect the rate of alcohol-exposed pregnancies, which can lead to FASD, to be high. So when we look at that, we know that if we want to make a difference in FASD, if we wait until women are pregnant, really that's too late. So we have to address prevention efforts with all women, or I would say all people of childbearing age. We can't just focus on those who are pregnant. I think that will probably make sense to most people. I'll let you take that.
So one of the things that both Mary and I like to talk about when we do our presentations is stigma, because I believe it's often the elephant in the room when it comes to FASD. So the next few slides are talking a little bit about that and how that plays itself out and some of the things that we can do to prevent that, or to prevent the stigma from happening. So this slide just talks a little bit about, for birth moms. I've gone through and coordinated the assessment clinic here in Waterloo Region for a number of years, and I have yet to meet a birth mom that has come through our clinic where this was something that was caused intentionally. Because of course, many, like Mary had just mentioned, upwards of 61% of pregnancies are unplanned, and women may just have not been aware that they were pregnant at that point in time. And with the other number that Mary had just reviewed before, that 80% of pregnancies are unplanned, and 81% of women drink, and the 61% of pregnancies are unplanned, means that there are a lot of alcohol-exposed pregnancies. Just because your pregnancy has been alcohol-exposed doesn't mean you're going to have a child with an FASD, but your risk definitely increases. And then, of course, many women also may be poorly informed of the dangers of drinking alcohol during pregnancies. There's not common messaging often around from healthcare providers about the safety of drinking alcohol during pregnancy. No safe time, no safe amount, and no safe kind should be the message, and to reduce the risk. And then, of course, there's women during their pregnancies that can't stop drinking alcohol during pregnancy. And of course, we need to find supports in the community that can help them reduce the risk and reduce harm during the pregnancy.
And I think there's a lot of misinformation that people find now on social media and on the internet. And so it makes it difficult to get the message out. We do really not know a specific cutoff rate around, if you drink this much, this will cause FASD. But we do know that alcohol is the factor for FASD. So the only message we can give is we recommend no alcohol of any kind, any amounts, any type, any time in pregnancy. That's the message we have to give because we don't know exactly how much.
Yeah, what the cutoff is. And I think the other thing around for birth moms, and when we talk about, FASD is 100% preventable, that adds to stigma, and it's not 100% preventable. I talk, if we have sex in our communities and we have alcohol in our communities, we will continue to have FASD, and neither one of those two things are going away anytime soon. So we can't say that FASD is 100% preventable.
And you still might see that, but again, that's how we're changing our language, is we're trying not to use that. So try not to use that if you can.
Mm-hmm. And then, of course, we talk about stigma for individuals living with FASD, and it's considered an under-recognized disability because there aren't outward signs, and it's often not diagnosed. So it's not a disability that you can see. We have said in the past it's an invisible disability, and that's actually language that we're changing also, because we've had feedback from individuals with FASD saying, hey, I'm not invisible. And of course they're not. So we're saying now that it's an under-recognized disability. It's not an individual in a wheelchair. It's not somebody that needs assistive communication devices often. So it's not recognized because you can't see that. There's no outward signs, and that adds to the stigma too, because we just expect more from them when really the disability doesn't allow them to sort of meet those expectations at times. And then individuals are often depicted as having, forever damaged minds. Some of the horrible language that we use around individuals with FASD, or they're willfully misbehaving, or being destined for a life of criminal behavior. And these are things we need to change. And like I said before, the strengths that we need to focus on is where that focus needs to be. On what do they do well, and how can we support them, and how can we adjust our expectations for things that they can do and not necessarily lower our expectations. And then the strengths and needs of the person may be overlooked or services not provided because it's believed that little can be done to improve the lives of individuals with FASD. And although we don't have a lot of information about evidence-based interventions, we have information about practice-based. We have information and evidence around practice-based interventions, so things that we think are working, and those are things that we need to focus on so we can improve lives. And then, of course, the brain is growing and changing, and there's innovative programs and supports. We have interesting programs and supports all across the province that are emerging, and I think that are providing us with some information about what things might look like. And then when children are coached in skills like co-regulation, I really like the word co-regulation. Self-regulation, I'm not such a fan of. I think that co-regulation of having someone in their lives or supports in their lives where we can increase the supports in their memory and their attention and their sensory experiences so their environments can be adapted, I think they can be much more successful. And then when services are provided routinely and children and families are given support and encouragement, they can learn to adapt and participate in a wide range of activities. And it's just really about accommodating and providing support where they can be successful.
Karen, I've heard people use the term with a child who has FASD, they need an external brain. Mm-hmm. And I know that's something that kind of bothers some people. Can you explain why?
So we used to use the term external brain for that support person that might help the child or individual. And we don't really like that term anymore because they have their own brains, right? Yeah, they're able to think and they're able to make choices. I like the term support person, and it doesn't even need to be a person. It can be things like visual schedules. It can be reminders on cell phones. It's those external supports that allow them to use the strengths and the things that they can be good at. And then, of course, there's stigma for caregivers. Caregivers are often seen as, and I just list them here, over-involved, uncaring, enabling, overprotective, willing to put up with bad behavior. It's really difficult for caregivers. They need to be there to advocate for their child. They need to reteach the teachers every year when their child goes into the next grade so that the educators understand what the needs are of the child, what works, what doesn't work. And that can sometimes be perceived as over-involved. And then caregivers have to manage difficult feelings around grief and loss. And there's lots of things that caregivers grieve. There's lots of losses in the lives of a caregiver. And it's not just sometimes lost potential of their child, but it's also I've had grandparents raising grandchildren. It's a loss of their retirement dream or spending their retirement income on supporting their grandchildren. It can be intimate relationships, the loss of those. It can be the loss of time with other children. So there's lots of things that caregivers grieve and loss in their FASD journey. And that definitely is a piece where if you can't see that through the clinical lens, parents really have a hard time moving forward with trying some different strategies to support their children. So that's something that in my work I do a lot of. Is I don't do the clinical grief and loss work, but I make sure that I can find someone that will do that with the caregivers.
And the good thing is we now have quite a few caregiver support groups across Ontario because of funding that's come to Health Nexus from the provincial government, and then transferred locally to different groups working on this. So that things are improving with services, things are getting better, and that's encouraging.
It's wonderful. And then I can, are you moving on? I'm just going to talk a little bit about the enabling, right? When we're providing that support and scaffolding for success, it can be viewed as supporting negative behaviors. And then, of course, they can also look overprotective, protecting the strengths and ensuring that individuals can live to their potential, and then willing to put up with the bad behavior. So understanding that FASD is a brain-based disability and understanding what is within control of the child and what isn't, right? And what needs to be addressed.
I think parents get good at picking their battles too.
Absolutely.
And so what might be a huge issue to one parent, a parent has a child with FASD,
that's nothing.
That might be nothing. It might be the bigger issues. And so I think that's where some of that sense comes from.
Yeah. Okay, so I'm going to talk a little bit about diagnosis and how we do that. So I like to say that it's sort of broken into three parts. There's identification, which is the process of which we sort of look at a child's behavior, look at sort of their profile and say, I wonder if FASD is happening for this child. And then there is the assessment process, which is what I'm going to talk about in a minute. And then there's the final outcome, which is diagnosis. So identification, I think, is the responsibility of everybody working with children. I think we're all, as early childhood educators, I think you're in a great spot to be able to be recognizing what FASD might look like in your setting and who might be a candidate for a potential assessment. And I'll talk a little bit about assessment and how it is really hard to sort of come about within our province. But just to highlight for you that it's every educator can be someone that can identify this. And just, you don't need a diagnosis to employ an FASD-informed approach in your setting. So FASD, it's a medical diagnosis, and it requires a multidisciplinary team, and that includes a pediatrician, a psychologist, a speech and language pathologist, and an occupational therapist. And then you usually have a social worker or a child and youth worker that coordinates that process, because it can be very time intensive and a little bit confusing for families at times, because it is a number of different appointments and a number of different practitioners that you'd be working with. And then there's the physical assessment, which is done by mostly the pediatrician, and then the cognitive assessment that's done by the other practitioners. And really, there's no unique profile for FASD. Everyone is definitely an individual and expresses FASD differently.
And that probably depends on when the alcohol was exposed to the child in gestation, right?
There's a lot of different reasons as to why everyone would look different. It has to do with the timing, the dose, genetic predisposition to issues. It has to do with the toxic stress mom maybe had during pregnancy, what was nutrition like, what was prenatal care like. It's very complex, and I think there's a lot of research still to be done in the area of why. Yeah.
Sorry.
There we go. So these are the new Canadian diagnostic guidelines for fetal alcohol spectrum disorder. And I believe, if I remember back, it was 2015 they were changed. So you may have seen children with previous diagnosis like FAS, so fetal alcohol syndrome, or partial fetal alcohol syndrome, or something else called alcohol-related neurodevelopmental disability. And we don't have those diagnoses anymore. It doesn't mean that that child doesn't have an FASD. We've just changed our terminology and some of the criteria around diagnosis. So we now have 2 diagnoses that we can give through our clinics, and it's FASD with the sentinel facial features and FASD without the sentinel facial features. And the facial features are not really relevant to the child's functioning. A small number of children actually have the facial features associated with prenatal alcohol exposure. And I'm not even going to review what they are because they're not really that relevant. The only time they really come into play for us when we don't have confirmed prenatal alcohol exposure for a child. So those 3 facial features, which is a thin upper lip, a flat philtrum, which is that bump under your nose, and then the eye openings are smaller, so it appears that your eyes are wider set apart. Those only come into play really when we don't have confirmation of prenatal alcohol exposure. Those facial features tell us that there was alcohol exposure, so we can use them for diagnostic purposes. But really with the FASD with the facial features, it's confirmed or unconfirmed alcohol exposure, and then you have to have 3 domains impaired to the 2nd percentile or lower. And I'll review actually in a minute what those domains are. But really what it means is 98% of the kids the same age and the same sex do better at the tests than those children would do. So you can have FASD with the facial features or FASD without. And then there's a designation that can be really helpful for some of the younger children. And it's called at risk of neurodevelopmental disability in FASD. And it's not a diagnosis, it's a designation. And we have to have prenatal alcohol exposure confirmed. And then we have concerns about clinical development. So they might not meet criteria for a full diagnosis, but the clinical team wonders, as this child ages, is FASD going to be something that's an issue for them? And they'll flag that as, yes, we do believe that this will probably be an issue for them. And then we would want follow-up or assessment done at that point in time. Because it's hard to assess things like executive functioning, which is sort of that frontal lobe, that planning, that organizing, that initiating at such a young age. So that it's a bit of a red flag that you can put on a child to keep look at their development, keep monitoring it, and then come back for some sort of assessment to see where they're at a later age.
Is that one very common, Karen, the at risk of neurodevelopmental and FASD?
Through our clinic, when we see the younger children, we've been using it more and more. Okay. Yeah. And early diagnosis is important. That's okay. Early diagnosis is important, but it's hard to diagnose early. So it's a bit of a catch-22. But regardless of if you end up with a diagnosis through the assessment process, you still get really rich information about a child's functioning, diagnosis or no diagnosis.
And in our area now, if a child we know has been exposed to alcohol or really any substance use, we have our child and development program following them, just because they may not have an issue but want to be followed to ensure that they get some support if needed.
Yeah, we have a nice pathway that way here in Waterloo Region, where even at birth, if we know they've been prenatally exposed to alcohol, they can go through infant and child development and then come in through the clinic if we have that confirmation. Yeah. So I'm just going to quickly review sort of the brain domains. So these are the things that we look at through the assessment process. So these are the areas that there's 10 areas, and you have to be impaired in 3 of these areas at the 2nd percentile or lower to receive a diagnosis. And of course, clinical judgment comes into that too. So it's not quite so black and white. So motor skills, that's something that our occupational therapist will look at, but also our pediatrician, and that's the assessment of fine and gross motor skills, the visual and motor integration, and then of course, the doctor will look at things like tone, reflex, and the OT will look at things like balance and coordination. And then the doctor, of course, too, will look at the neuroanatomy and neurophysiology. They'll measure the head circumference. Kids with an FASD don't necessarily have a smaller head, and often they don't. That's also a misnomer, but sometimes they do. So the doctor will take a peek at that. Some children with FASD may have a seizure disorder. They may do brain imaging. We very rarely do because you can't necessarily see FASD and very often cannot see FASD on a brain image. They'll also look at sleep, and then they can also rule out any sort of genetic disorder that may mimic FASD. The psychologist will look at cognition, so that's your IQ. So they look at the 5 different areas of IQ, and often children with an FASD don't have an impairment, like don't have a co-occurring intellectual disability. They actually know a lot about a lot, and they are often able, they're often very verbal. They can reason, they have, you know, some of those judgments intact. So cognition is not something that is indicative of brain differences. They actually know quite a bit about the world. Then we also look at language, and that's their core language skills. So the words they know, the vocabulary that they have, they're quite the talkers. Often their expressive language is much more stronger than their receptive language, but they can also have impairments in their social language. So understanding social cues, understanding nonverbal language, those sorts of things. And that's why friendships can be hard. And relationships can be hard for individuals with FASD. And then executive function, in my opinion, is that sort of the hallmark of where kids with an FASD struggle. And I don't think that any child that has come through our assessment clinic has not received an impairment in this brain domain. And that's the higher level thinking skills that include organizing, controlling one's own thoughts and behaviors to meet those long-term goals. And it includes like working memory, inhibiting behaviors, planning, problem solving, that cognitive flexibility. Sometimes they're pretty rigid thinkers. And that can be definitely an area of difficulty for kids. And then you have to be able to do all those things. So have your working memory happening, inhibit your behaviors, plan, problem solve, and manage your emotions while you're doing all those things. And that can be really, really difficult for kids with FASD. And then we'll look at their memory, and that's their overall memory, the way they understand and remember information coming in through their ears and their eyes. And then we also look at attention. And do kids with an FASD often have a co-occurring ADHD? Sometimes, yes, but sometimes the attention and the distractibility is actually part of the FASD. And it's really hard for the team to tease that apart. And I often talk about, well, if ADHD medications are effective, then great, that's wonderful, but doesn't necessarily mean it is an ADHD.
Yeah.
And then we look at affect regulation. So this is something the psychologist looks at through the clinical assessment. And if they meet the DSM criteria for any sort of anxiety disorder or depressive disorder or mood disorder, they would receive a hit in that brain domain. And then some of those are listed there. And then of course we look at their adaptive behavior. So those are their social skills, social communication, how can they keep themselves safe in the community, how do they interact with other people, how are their concepts and their understanding of time and money, those sorts of things. And often kids with an FASD will have significant impairment in those areas also.
So both of these domains would be ones you'd see commonly? Commonly,
yes. And then there's actually one domain we don't have listed there. It's the 10th one. It's the academic achievement. And it is where if you would receive a diagnosis of any sort of learning disability, you would have an impact in that area. So those are the brain domains that we look at. And then there's also some other features that are commonly associated with FASD that we take a peek at. One that I often highlight with parents, and we really sort of dig deep and try to figure out, are sleep issues for kids with fetal alcohol spectrum disorder. And we did a small study through our Waterloo Region FASD clinic a number of years ago, and we sent 10 kids away for a sleep study, and all 10 came back with a diagnosable sleep disorder. And there's a number of things you can do about that. There's medications that you can try, but also just simple sleep hygiene strategies, like making sure your bedroom is cool and dark, making sure there's not things that can distract kids, things like putting down your technology an hour before bed, making sure you're not hungry, having a nice light snack before you bed. All those things can assist with sleep. But that's something I definitely see a common thread through a lot of the kids that I work with, is that they don't sleep. And when you're not sleeping well, you can look inattentive, you can look irritable, you can look not happy. So that's often something that we try to try to address.
That makes it harder on parents too. If the
Well,
child isn't sleeping,
And then
the
parents aren't sleeping,
sleeping.
and then they're not able to cope as well as they would be able to, right? Because nobody in the house is sleeping, and I've seen that for sure.
Yeah.
So sometimes if kids, we know they're never going to get an FASD diagnosis because we don't have that confirmation of prenatal alcohol exposure, we'll delve into a psychological assessment, but then also a sleep study. And because if kids are sleeping better, then we can really see an improvement in behavior.
Mm-hmm.
And the other thing that can also improve behavior is helping manage the sensory world around them. Kids with an FASD have significant sensory needs. I don't think I've met a child that doesn't have some sensory needs. And I'm sure that the educators on the line are very up to date on what that can look like in children, right? So it's the sight, smell, touch, taste, hearing, that vestibular system, the proprioception, and that the processing of all the information. They don't have those filters to filter out the information around them, and that can then look like behavior. And then, of course, there's some other physical and medical challenges. Like I talked about before, FASD is not just a disability of the brain. This is now what we know as a disability of the entire body.
Mm-hmm.
And then we used to think that kids with FASD were smaller, and we're coming to understand that that's not necessarily the case. So we do, take a peek at the growth, but it's not necessarily something that's indicative of an FASD. And then there is the new and emerging research done on dad's use of alcohol. And I have some cheat sheets in front of me that I just want to refer to when I talk about this, because I want to make sure I get the information right. But delayed growth is significant to understanding a person's development. Oh, that's not the right line, sorry. The only cause of FASD is maternal alcohol use in pregnancy, right? So if dad used alcohol, it doesn't mean an individual is going to have an FASD. But there are other factors that can impact the development. And those are other substance use and paternal use of alcohol. So alcohol used in breastfeeding. So research has determined that if a man drinks significant amounts of alcohol prior to conception, this can affect his sperm, particularly in the area of sperm motility, which means
how it swims.
How it swims, that's a Mary term, and his ability to reproduce. So the quality of the sperm and the man's ability to reproduce. And those are preliminary studies that indicates a link between paternal alcohol consumption and negative childhood outcomes. And I think we'll learn more about that as time goes on. But it's definitely a fascinating area of research. But no, dad cannot cause FASD. But we do know that quality of sperm and some of those outcomes can have an impact
on the developing child.
On the developing child.
As any substance use can.
Mm-hmm.
So you might be, one question I wanted to ask you before I started, yeah. Karen. So if I was concerned about a child and I thought maybe the parents should be looking at some sort of diagnosis, is it easy to get that, or what should I do about that?
Well, I think that's sort of two-pronged. I think if you're wondering about a child, that's a conversation to have with parents, and that needs to be done in a respectful, absolutely. Caring, you need to have a relationship to have those conversations. And I think before you even have that conversation with a parent, you need to do your research, what is available in your community, because the worst thing that could probably happen is going to a parent saying, I think this is, maybe this is potentially something going on for your child, I'm wondering about, and that not having any recourse for assessment.
Yeah.
So I think and do you have to have a diagnostic clinic in your region to be able to have those conversations with parents? Absolutely not. But I think you need to sort of have your research done beforehand so that at least there's something there to offer, because the worst thing that could happen would be, I think your child has an FASD and now we don't know really what to do about that. So it's hard to get a diagnosis. Not every region has a clinic. So you'd really have to look in to see what is available in your community.
And I know
or beyond.
When I started out learning about FASD in Waterloo Region, I was shocked that we only had 10 diagnostic spots a year, and it still remains at that. It
still remains at 10. So with that 4% prevalence rate, I think I had calculated that we probably have 6,000 children living in Waterloo Region with an FASD, and we have the capacity to diagnose or to assess 10 children a year. And actually, it's not funded by the government. In our region, it's all provided in kind by local organizations. And there's not a lot of regions that have a model like ours. So I think there's a couple others, but if you may actually be in a region that does not have diagnostic capacity.
It's important to find that out.
It's important to find that out before you have those conversations.
So we want you to, I was really excited when I heard that this group of care providers wanted to know about prevention of FASD, because a lot of you work with many women and people of childbearing age, and as we talked about, waiting till pregnancy is really too late, so you will have some influence on that population. So I thought it was brilliant when this group asked for this webinar, and I'm hoping we can give you something that's helpful. But I think it's a great way that you're thinking, so I hope you continue to think that way. So why should you be concerned about FASD? Well, as a population, we should be concerned because of the cost. And again, there's different studies and different numbers, but the Public Health Agency of Canada has estimated, and based on studies, that $5.3 billion per year is spent to support people with FASD from birth to 53. And some people will live beyond 53. So 5.3 is what they've have. But CanFASD did a study. It's by the Canadian Research Network. And this is an economic researcher, and he estimates that $9.7 billion per year is spent. You can see there's a big difference between those numbers. Some of the estimates are that it costs $1 to $2 million per individual with FASD to support them throughout their life. And so that's a lot of money. And then we do know that the rate of FASD in Canada's prisons is estimated to range from anywhere from 10 to 23%. And most of those people that are in the prison will not have an FASD diagnosis, and they would have been stigmatized. They would have not probably gotten the supports that they need, and therefore they are labeled as bad people, and the people that make bad decisions, and they don't get the support they need, and then make decisions perhaps that get them in trouble with the law. And it's a case of we don't have the supports and services available to support those people, and think about how big of a waste that is, much less the cost of it. So this is one of the things we need to think about when we're talking about FASD. It is a big deal when we look at cost. One of the other reasons we should be concerned about FASD, it's a lifelong disability. It doesn't go away at age 18. It doesn't go away at age 5. It's lifelong. And as Karen indicated, it's under-recognized. People with FASD have challenges in just daily living. Learning how to take the bus from A to B can be a real struggle for some people. They may have done it once, and they can't remember how to do it another time. So that you can see how that would be really limiting and making life difficult. They need support with motor skills, physical health, learning, memory. So some of them, can't remember when their child was born. Attention, communication, emotional regulation, social skills, really to reach their full potential. But if we can put some of those supports in place, we can see a much better outcome for people living with FASD. Many, as I said and Karen said, are undiagnosed, which leads to a lot of people judging them. They tend to speak well, as Karen said, so they can parrot what you've told them. They can say exactly back, and people think that they understand what they've said. And in fact, they're just really good at parroting, and they don't really understand the information they've just repeated back to you, which creates a lot of stigma, a lot of judgment, which leads to low self-esteem, disappointment, mental health disorders, and things like that. So we really feel like we need to think about this, prevent it, but also provide the supports that's needed for those who have FASD to prevent the cost to our system, but also to help people reach their full potential. And there are things we can do to reduce the incidence, so therefore we should do something about it. So that's why we're here today. You need to be aware of the issue before we can address it. And the more studies we do, we can see that the prevalence rate we know is increasing just because of the studies we've done. We know better interventions to work with those who have FASD. So we can reduce the incidence, so we need to think about how we can prevent it or at least decrease the incidence. Mm-hmm. Can FASD estimates that Canada would benefit greatly if we were to devote resources to the prevention of FASD. And we're not trying to pit prevention against intervention and supports, but we do need to address prevention, because if we can prevent more, then we'll have less need to do as many interventions. So in 2013, this is the last study I've seen, if we spent $150,000 on the prevention of FASD, and when I say prevention, it has to be evidence-based prevention efforts, not just what we think will prevent it, we would save $1.6 million. And if you put in $150,000 and you got $1.6 million in return, that's a pretty good return on investment. And so prevention is always a hard sell. And so we need numbers like this to show that we're silly not to try and address the prevention of it. So let's talk a little bit about why are women drinking more. Women didn't just all of a sudden decide to go out and drink more, but really for the past 20 years, the alcohol industry has targeted women, and because they knew they could make more money if they targeted women, and women typically drank less than men, and we call that the pinking of the alcohol industry. And I'll show some slides later, but you know, the marketing is in pink. You can see women on the front of the packaging. You can see messages targeted to women. So definitely that's something that happens. Marketing restrictions, when you think about it, are very different for tobacco than alcohol. And there's way more restrictions for tobacco than alcohol, but each of them are equally toxic that cost our system a lot of money. So I argue that we need to address alcohol the same as tobacco, or at least we need to think about it. And if we look at our history, we've gone from prohibition to more controlled access, and then culturally, really only men drank for a while, and then women were targeted for marketing. So we see a cultural change. We see it more acceptable for women to drink. In fact, we see it not acceptable for women not to drink when we look at some of the ads and some of the things that are coming out. And now we're seeing a relaxation and erosion of controls in recent years. So the sale of alcohol in grocery stores seems like a great thing, but when we look at it, it really isn't a great thing for our society, because we know if alcohol is more readily available, people are going to drink more at riskier levels. And that would include women if we're just talking about FASD. So that's sort of where our history has come, and we need to think about how we've gotten to where we are and change some things so that we can maybe decrease the incidence of women drinking. So here's some of the alcohol marketing that we see. It's everywhere. It's on Facebook, it's on Instagram, it's on billboards, it's in parenting magazines, lots of things. And alcohol is really promoted as a stress reliever and something that all moms deserve. And so the two on the right are in the pink, you know, this beer is making me awesome. And those messages are kind of targeted to women, and it's 5 o'clock somewhere, so I should be able to drink at any time I want. You can see the marketing there for women's skinny girl margarita. Women want to drink, but they don't want to gain weight, and therefore that's a definitely targeted product to women. And then this one I saw actually on my niece's Facebook feed, and I was a little bit appalled, and promoting a water cooler filled with wine, and wow, this is great, basically. How wonderful would that be? So these are the things that I actually did talk to my niece about that
conversation.
I don't know how well it went. I tried hard not to offend anyone, but it is a hard thing to address, but I do think we need to speak out against it. And then I wanted to show a few little videos. I hope they're going to show. And these are done by Wellington Duffer and Guelph. And they're they're great. I think they're called Last Call, I think.
Yeah.
And they really do a good job at showing you perhaps what I've been talking about. So let me try here.
Yeah, that's right. Yep.
My name is Julie Elston Height, and I'm an Orangeville native. I grew up here, and I am known online as Sober Julie. I'm 9 years sober from alcoholism and addiction, and I write about it on a blog. I decided when I became a person in recovery that I would share my story.
We're going to back up for you.
Try.
Maybe press play again.
I didn't start drinking until my 20s, but when I did, I really loved the way it felt. I was suddenly way more confident, way more social. I was the life of the party. People looked at me and paid attention. And Friday night at 5 p.m.
Okay, I'm going to try it one more time. My apologies. We're going to try and call it up again. So
It's actually working, Mary, and yeah, don't worry, it's working. We can hear it, no
Oh,
problem.
you can?
Yep,
My
yep, yep,
apologies.
no problem.
We'll try again.
Yep.
The wine bottle would be opened, and it was like this ceremony inside myself of opening the bottle, and then that was, I deserved this. I started really hating who I was because I couldn't actually be that fantastic person that I worked so hard to be. I didn't believe I was that. I was 36 years old and I woke up, and there'd been many blackout nights. This day I woke up, and before I opened my eyes, I knew something terrible had happened. And in fact, what I had done in the early hours of the morning was write a suicide note. And for the first time in my life, I knew that drunk Julie was too powerful, that I couldn't control her, and I needed help. Alcohol can kill people, and I was super close.
That's one of them, and we're going to show one more. It's even shorter, at least I hope we're going to. Hold on.
For years and years, the marketing industry had always targeted men for their alcohol ads. And what happened in the early 2000s is we saw a shift in marketing. The alcohol companies got very wise. They always understood that the women were the people in the household who spent the budget. So the marketing company targeted them for alcohol. There's the mommy wine culture, and you can go online and you can buy yourself a flask that is disguised in a diaper bag. New moms who already have all this responsibility and all this stress, and now we're being told, hide it and use it. And to me, this is catastrophic. What is going out there for your children that inevitably they're going to end up seeing somehow, that we need wine or we need alcohol to deal and cope with our kids. It's a lack of self-care, it's a lack of understanding, and we're being conditioned to accept it.
So again, she says it much better than I can ever say it, but talking about how our culture has changed. If I think about where we were when perhaps my mother, who's in her 90s, may have talked about alcohol or thought about alcohol, is much different than people my age or even people my niece's age. So, you know, things have really changed, and I think we need to think about how that has changed. Is that good for our culture? And how can we as a society and as an individual make a difference in that? So I'll let you sort of think about that. And I think even some of those things creep into our behavior, even if we're aware of it and we don't know about it. We're trying to do things that promote alcohol consumption, even though we're not even cognizant of it.
Yeah. Louise is saying, make sure your presentation is back on.
geez.
Oh, go back to, yeah.
We're trying, Louise, hold on.
And then the PowerPoint.
Where's that one? Down there. Okay,
Oh.
that's okay. Maybe we'll go down. Here we are.
Here we go.
Okay, can you see it now, Louise?
Yeah. Oh, good.
Yeah. So what I wanted to say, and that Karen and I wanted to say, is you definitely have influence, and in fact, you have way more influence than you think you do. You have influence on your own behavior, and your behavior is a role model for all those around you, including the children you care for or the children that you parent. And then you have influence on your friends and on your colleagues by the things that you say in a way perhaps that they can hear it. You have influence on the children that you care for, on the parents you interact with, and lastly on the bigger system and the policies that are put in place. And just depends where you are on the spectrum. If you want to work on your own behavior, work there. If you can work on the bigger system, by all means do that as well. So your own behavior, so what would you need to do to sort of to think about your own behavior? Well, you need to be aware of what I talked about, Canada's low-risk alcohol drinking guidelines. And they were based on research and basically looked at what level of alcohol could people drink at that wouldn't increase their risk on their health or their safety. They do acknowledge that not drinking is best. So this doesn't mean that you should be drinking 2 drinks per day or 10 drinks per week. But they tried to create a guideline knowing that people were going to drink as to what would be a safe amount or a safer amount. I shouldn't use the word safe. So for women, the recommended amount is no more than 2 drinks per day or 10 drinks per week. And you can't save all those 2 drinks up per day and use them in one day on the weekend. That would be called binge drinking. So, and for men, it's 3 drinks per day and 15 per week. And that's because men metabolize alcohol differently, usually weigh more, all kinds of things. And I'll go over that in a minute. But I have had women say that it's sexist to have different guidelines for women and men, and it's not. It's based on research and that alcohol affects women to, at the same level as men, to a greater amount on their health. So the message that they have on the Canada's Low Risk Alcohol Drinking Guidelines, that if you're planning to get pregnant, if you are pregnant or you're about to breastfeed, no alcohol is the recommended choice. I wish they had added in if you think you might be pregnant, because most people will wait until their pregnancy is confirmed before they stop drinking. And I wish people would stop noticing when women stop drinking and ask them if they are pregnant, because that really doesn't help at all. If a woman chooses not to drink, so be it, no big deal. And those are the things we can kind of change in our own behavior. Tell your friends and family about Canada's low risk alcohol drinking guidelines. I've tried that at parties. And actually,
how did that go over?
Well, actually, people are okay with it. They usually don't know about it. And so I think it's important to chat about it. Usually there's some jokes about it. Right. I joke as well because that helps to get the message across. But people are usually quite unaware. And that's why I think it isn't a bad discussion starter. And then you need to understand why alcohol poses more risk for women than men. And the other thing is there's a website called rethinkyourdrinking.ca, and it is sort of a self-learning website, and it has different things on it that are quite good, so you could refer people there. So be a positive role model, assess your own behavior, and I asked, do you brag about how much you drink? Well, if you do, you maybe want to change that a little bit. Do you share alcohol memes that encourage overconsumption of alcohol on social media? Again, think about whether that is the type of behavior you would like to promote. Do you challenge others in correct alcohol advice? And when I say challenge, I think we need to say it in a way people can hear it. And that's sometimes something that you learn by maybe not saying it the right way one time, and then you get better at it the more you move on. And some people won't ever hear your message, but others will hear your message. So I encourage you to try. Discourage others from promoting alcohol use. So some people will encourage others to drink alcohol when they've said no. So you could just say, oh, no, she said no, just let her make her own choice, you know. Do you offer alcohol-free options at your home, or do you only have alcohol available when people are over? Do you drink when children are present? If they see you drinking, of course they're going to drink as well. Children do what they see, not always what they're told to do. Do you ask your children to get you another glass or can of alcohol? Again, that's going to be promoting alcohol use as children get older. And do you ensure you're using reliable birth control if you're drinking at all to prevent alcohol-exposed pregnancy? So we're not saying people can't drink. We're just saying if you are drinking, make sure that you are not using, you're using birth control to prevent an alcohol-exposed pregnancy.
Can I add one in there, Mary?
Sure, of course.
I think too, recently I've seen more and more social service organizations raising money through various
Yes.
endeavors that involve alcohol.
Yeah.
And I wonder if we need to start rethinking that practice. You know, whether it's a wine night, or I saw somewhere that a hospital had raised money with selling a wheelbarrow full of wine, and I didn't think that was maybe the best choice. So some of those practices I think we can look at too.
For my own daughter's soccer team, they're 15-year-old girls, and they want to sell liquor baskets. And I spoke up against it, that I don't think that's a good thing for 15-year-old girls to be seeing us doing. It just plants a seed for people.
And there's a lot of other options.
Yeah, absolutely. And so the risk of alcohol use for women are greater because, one, women weigh less, typically. Doesn't mean all, and it means that it takes less alcohol to produce the same level of intoxication as it does to men. We have less water and we have more fatty tissue metabolically, and therefore alcohol is at a greater strength for longer periods of time in our body, and therefore it does more damage the longer it's in our body. We know it's a toxin. We have lower levels of the enzyme alcohol dehydrogenase, which helps to metabolize alcohol, and therefore, again, we have alcohol in our bloodstream for longer periods of time. Our changing hormone levels, so change throughout your cycle, can affect how a woman metabolizes alcohol. So for these reasons, alcohol drank at the same rate as you would for a man leads to a higher risk of heart disease and stroke, liver damage and breast cancer, and some of the reproductive issues. One is FASD, like we talked about, but also alcohol can reduce fertility. It can increase your risk of osteoporosis, which is bones that are more holey, more porous, and therefore weaker and break more easily. It can increase your risk of addiction, and also it can cause brain damage in adults as well. So there are a lot of risks for women. I do think we're starting to hear a little bit more about them, but I'm hoping that you can start to share these with some of the people that you're interacting with. And how could you influence your friends and colleagues? Well, I would suggest you share correct information in a way that people can hear it. And that will be different for every person. And as I say, try it and see how it goes. If it doesn't go so well, try it in a different way another time. So share information about the low-risk alcohol drinking guidelines. Share information about the risk of alcohol use for women. Share evidence-based information regarding the risks of drinking alcohol in pregnancy. Encourage women to think about alcohol and birth control use together so you can prevent an alcohol-exposed pregnancy. Also, don't respond to conversations that involve idolizing or promoting alcohol use. You know, the person that comes in and said, oh, I had a great weekend, you know, I drank, 20 drinks over the weekend, and laughing and promoting that. Just don't respond to that and don't encourage it. I think that's sort of how our culture of alcohol has moved ahead, and we are drinking more. So we can just stop that by just not responding to it. And by sharing the ways that you discourage alcohol use in children, and that could be things like not letting them get the drink that you wanted, not drinking in front of them, talking about alcohol and the risks of that, all kinds of things. How can you influence the children you care for? And this sort of comes to more policies that Karen was talking about a little bit in your workplace. So ensure that your workplace is free of any pictures or symbols of alcohol. And sometimes they're there and you don't even know it. But you're going to be more aware now because you're going to be looking for it. And speak out against any fundraisers, as we said, that might involve alcohol sales. Ensure there's no toy dishes or toy items that depict alcohol or wine glasses, things like that. Encourage the children you work with to make their own safe decisions on various topics. So if children learn when they're young to make a safe decision out of a few things they can choose, then they gain the confidence and the self-esteem to make safer decisions as they get older. Build their self-esteem. Again, if you have more self-esteem, you're less likely to drink at risky levels. And ensure that alcohol is not talked about if children are within earshot. So certainly not that, well, I had a great weekend, I drank a lot conversation. We don't want to have that when kids are around. And how can you influence parents? Well, I'm hoping you can post or have handouts regarding the dangers of alcohol use in pregnancy, and you can look to Rethink Your Drinking. You can look to Canada's low-risk alcohol drinking guidelines. You can have handouts around the low-risk alcohol drinking guidelines. You could create policies for your establishment that outline the purposeful culture of having no symbols of alcohol or alcohol advertisements, or around the fundraising. You could have that purposely in your policies. You may already not do that, but when you put it in there purposefully and parents are reading that, they then start to think about that and question other areas in their life where that might be happening. You can post articles in your newsletter, website, social media channels, all around prevention of FASD and the risks of alcohol use. You can create some articles, you could do some blogs, you can start a conversation, all kinds of things that might not be a challenging way to discuss it, just a nice, let's have a discussion sort of thing. And there is a poster called Sandy's Law. Whoops, I want to go to it. It's this. And you've probably seen it, or at least I hope you have. We're trying to get the poster changed because this was made many, many years ago. And the woman is obviously 8 months pregnant. So we'd like it to sort of show a woman who's maybe not pregnant, because that's when we want women to start thinking about it. But every establishment that sells alcohol is required by law to post this. Some people post it behind the counter, some people post it behind things. It needs to be in a visible location. So oftentimes when I go into a place, if I don't see it, I just say, do you have the Sandy's Law poster? Here's where you can download it there, and say, do you know that you have to have it in a visible location if you're selling alcohol? And just leave it at that. Usually it changes. If it doesn't, I might ask them again another time, but usually it does. I think businesses are becoming a bit more aware, but any place that sells alcohol should have this sign up. And as I say, we're hoping to change it. Here's some of the posters you can find online. You can get them from many places. This basically shows what a standard drink is. So 12 ounces for beer, 12 ounces for a cider cooler. A standard drink for wine is only 5 ounces. And most of our wine glasses now hold at least 10 ounces. And that's basically 2 servings of alcohol right there. So we need to be aware of the serving size. And I think this poster does a good job of this. And then for distilled alcohol, 1.5 ounces is a standard drink. So some people may be think they're having 2 drinks per day when they're actually having 4. Yeah. I'm sorry this poster isn't very good quality, but this, put up some posters like this around your low risk alcohol drinking guidelines so that people are aware. Most people aren't. And the more we talk about it, the more people will be aware. Yeah. And the last thing I'm hoping you gain some confidence to do is influencing public policy. We do know if we change our public policy, that will have a bigger influence than just telling people about alcohol. For instance, think about the seatbelt law. So before, when seatbelts were not made law that you had to wear them in your car, we told people that it would make them safer, but how many people did? Once it was law, now I don't really know anyone who doesn't wear seatbelts in the car. So changing policy can make a big difference on our behavior, and in the long run, a big difference on the cost and the harms that things can do. So many people think they don't have any effect on public policy, but even an email, a letter, a phone call, or a chat can affect the public policy and how your politicians vote when they're in Parliament and bring forward bills. So I encourage you to not think about, well, me phoning will make no difference or me emailing will make no difference. It does make a difference. I have had MPPs in my family, and sometimes they're just basing their opinion on 1 or 2 phone calls. Right. So it's important to do that advocacy. You can advocate on your own or even a part of a larger organization, maybe, and I don't know if is there an early childhood educator association, things like that. I've done a lot through the Registered Nurses Association of Ontario because that group has a bigger voice than me individually. You can encourage your friends and colleagues to speak up, and you need to know that we do not have an alcohol strategy in Ontario or in Canada that aims to promote safer alcohol use to prevent alcohol and social problems in our society. So in Ontario, we need to create an alcohol strategy. There's been talk about it forever, but we still haven't seen one come forward. So we need to ensure we have one so that we can reduce the harm and use alcohol in a safer manner. Here's some of this is a model that was put together by first Public Health Agency of Canada and then by this research network we talked a lot about, which is CAN FASD. And it looks at different ways we can prevent FASD. And so the point of this model is we can't just work in one area like level 1, which is raising awareness and health promotion. We need to do action in all of the areas. So for level 2, where it says a discussion of alcohol use and related risks with all women of childbearing years and their support networks, that's targeting all women and men of childbearing age. So that's before they're pregnant. So some of the discussions that healthcare providers should be having with all women of childbearing age to talk about alcohol use and ensuring they're on birth control and things like that. Level 3 is ensuring that we have the supports for pregnant women so they can stop or reduce their use of alcohol, and they have housing and they have appropriate nutrition and social supports. All of those things will make a difference to a pregnant woman that's trying not to drink in pregnancy. And then level 4 is after the baby's born. If the child has been exposed to alcohol, some interventions to ensure that they're being followed. And then if the mom has been able to stop alcohol use, how do we continue to support her with breastfeeding and not drinking again, because sometimes she'll become pregnant again. So all of those levels of support are important. And at the middle of this is supportive alcohol policy, and that did not used to be there, and it was added in a little bit later by CAN FASD. And I think it's a really important thing that if we have action in this area, we will see a big difference in FASD. And we should see some more resources for prevention that begins before pregnancy with all people of childbearing age. We should emphasize that having awareness campaigns is not enough, that we need other strategies. It's very easy for people to say we've done an awareness campaign, so we've done our bit to prevent FASD, but we know through evidence that that's not going to make a difference by itself very much. So we have to see some other actions as well. We should see funds for healthcare providers so they do have those brief conversations with all people of childbearing age. We should see funds for services for pregnant women who are struggling with alcohol, and I would say substance use. They often go hand in hand. If someone drinks alcohol, they're often taking other substances. And then purposeful education of school students. So around alcohol, around FASD are really important things. And if you're thinking about influencing public policy, these are the things that we know from evidence that will make a difference in the amount people drink and if people drink at risky levels. So regulating the availability of alcohol, so where it can be sold. So now we have it in grocery stores. It probably will be hard to go back from that, but we certainly don't want it sold in convenience stores because it will be more available. So we need to speak out about that, because that will not be great for our province and our society as far as alcohol harms are concerned. We need to control affordability. So alcohol needs to keep pace with the cost of living, because if alcohol prices don't keep pace with the cost of living, it's actually cheaper in the long run, and therefore people will use more. And that's done through taxes and other price controls. Placing restrictions on marketing, similar to tobacco marketing, would be best. So tobacco marketing has way more restrictions than alcohol marketing, and we need to be heading towards that model because it works and it's important. Developing drinking and driving prevention and deterrence, and certainly we're doing that. We just need to continue. Modify the drinking context. Make sure we can only drink in certain places. We don't want to be drinking in places where there might be children around. We have a legal drinking age of 19. We want to keep it there in Ontario. Many of our other provinces have it at 18, but we know if we lower the drinking age, that we have more people drinking and more people drinking at risky levels, and that often continues as they grow older. We need to develop education and persuasion strategies like the Sandy's Law poster that I showed you. And then we need to ensure we have treatment and early intervention services for some of the people that know they're heading down that road where it's at risky levels, and make sure there's no stigma attached to that. It just treat it as a disorder like heart disease or cancer or something. So in the end, I just want to say that you have influence, you have more power than you think, and I encourage you to use that. Think about what you can do to reduce the risk of alcohol use for women and men, I would say, but women we're concerned about because of FASD, and think about what you can do to reduce the incidence of FASD as well and reduce the stigma. I don't see any questions here, but I'm not sure.
Yes, there are 3 questions that have come up already. Yes, and I do encourage you to post your questions. So I'll read them out for you. One came towards the beginning. How do you propose to address the shame and guilt associated with drinking for women who have drank during the perinatal period?
That is always a hard one. I think thanking women for sharing. I think if they've shared that with you, I think they've done you a huge honor. I think I would encourage them to do what they can from now on. So let's say they had some drinking in the first 6 weeks. They should be at least telling their doctor and healthcare provider about that. But there's things we can do, like eating well, ensuring your stress is lower. If they can, not drinking at all from then on, making sure that their stress is low, they have social support. All those things can make a difference. We know the child develops throughout pregnancy. We know the brain and the nervous system develops throughout pregnancy. So trying to create the best environment you can. And I think reminding women that, 60% of pregnancies are unplanned, and that 78% of women are drinking. So we will have some of that. It is very common. To go on from there. Did you have any?
Yeah, it's not an isolated incident, right? This is something that's happening to a lot of women. And I think that if a parent comes and shares that with you, that, like Mary said, is an honor. And it probably took a really good relationship between mom and you for her to share that information with you. So you've done something right?
And I would say in doing these webinars, Louise, I would say that many people listening will have had some alcohol in pregnancy. Karen might have, I might have, but we do what we can from when we know. I think that's the best we can tell people, and sharing that, and don't keep it a secret. Don't hide it.
Thank you for very. Yeah.
I think the one thing I would add, Louise, too, if women are really struggling with that and that knowledge that this is something that's happened with them, counseling is a wonderful option, and you don't necessarily have to access a counselor that has specific information or training in FASD, but what I often recommend is a specific counselor, and usually they all do have training in grief and loss. So that's something that you can access in your community too.
Great insights. Thank you very much. The next question we received when you were talking about diagnostics was, what if there's suspected FASD but no confirmation of alcohol exposure? Do they still fit in the designation category?
So if you don't have confirmation of prenatal alcohol exposure, you're likely not going to get a diagnosis unless you have those facial features. And it's really hard, number one, to access a practitioner that knows how to assess those facial features. But also a lot of the kids don't have the facial features. We don't have the citation for it, but I believe it's only 10% of the kids actually have the facial features. So I run into this all the time with families where we don't have prenatal alcohol exposure confirmation, but it doesn't mean that we can't use an FASD-informed approach with them. An FASD-informed approach is not going to harm anyone. So that would be the way I would address that. And then I would also look at things like, how does the child sleep? You can address that without the confirmation of prenatal alcohol exposure. You can address their sensory issues. You can have a psychological assessment done with a psychologist that's FASD informed. So there's a number of things you can do. You may never get that diagnosis, but you can definitely use that FASD informed approach.
Karen, I thought I heard that they were also using a confirmation by another family member.
Yeah, so it doesn't have to be. So the kids that I work with live with all sorts of families. They live with adoptive families, they live with grandparents, they live with biological families, they live in foster care. So you don't necessarily have to hear directly from the biological mother that there was drinking during pregnancy. You can hear that from a reliable source. And you have to use your judgment about what a reliable source looks like. So it can be an extended family member with the interests of the child, sort of the best interest of their child at heart. You can look at the social history from adoption. We've used arrest records where a mom was intoxicated and arrested during her pregnancy. We use that as confirmation of prenatal alcohol exposure. So you can get creative in how you found out that information, but it doesn't have to come directly from a mom.
Thank you very much. And there was a third question that was typed in there. Do you have suggestions for responding to the jokes that might be made by parents, such as, "I need a drink," without harming the relationship? That would typically be said amongst friends. So how do you do that?
I would maybe respond like, well, I wonder what self-care strategies that you have, right? Like, what are some of those other things that can be used instead of alcohol?
I think to acknowledge where that's coming from. You sound a little stressed. What else can we use other than alcohol to decrease stress? Acknowledge that feeling, because there's a feeling.
Yeah, there's a lot of power in validation.
Yeah. And then maybe then you can get some ideas from them as well. I find too, people often will joke about it and I just go along with the joke, but I've also given my message around, you know, we're feeling stressed. You know what I do when I'm feeling stressed? I go for a walk, or I phone a friend, or I go to the hot tub, or whatever you have access to, you know, are things that can really make a difference. But that's a very good question. And I don't think we have the answer to that. Yeah. I think we know what has kind of worked for us, but it doesn't mean it will work for you. And I know when I talk to women about alcohol in pregnancy, because that's what I did as a living, lots of times when I first started doing it, I was not good at it. But you learn what works and what doesn't work and how people can hear it. So I encourage you not to stop talking about it. I encourage you to sort of think about, well, it didn't work so well. Let me try this next time.
And I think something to keep in mind when you're working with parents and some of the strategies that we talked about how you can inform them about alcohol use and some of the risks associated is remembering that some of the parents that you're working with may be living with FASD themselves.
Yeah.
Right? So just making sure that you're providing the information also in an FASD informed way.
And I've often found some of the women that I worked with that may have had FASD not diagnosed, that when I talked to them a little bit about that, they were so relieved that someone got them that I would see a weight come off their shoulders. because they didn't feel
Well,
like
yeah.
they were labeled anymore.
Yeah, and because often life has been a struggle, and they've been told that, you know, and have internalized feelings of I'm not good enough, or I'm dumb, or I'm stupid, or these feelings. And when they find out this is the reason for some of their struggles, they're like, oh, well, that makes sense.
Yeah.
And it takes that away from who they are as a person.
Good question.
Great. Yeah, thank you. And it sounds like that answer was helpful also, so that's great. I want to thank you for your presentation in case some people are leaving at this point. And I will do a very short presentation on Best Start Services, but that will also give an opportunity if anybody has more questions, they can type them while I'm talking, and then in 5 minutes we'll recap and see if there's anything else that has come up.
Sure.
Okay, but thank you so much for all the information that you've provided.
Thanks for the opportunity.
Yeah,
That's great.
thank you.
So many of you are probably familiar with Best Start by Health Nexus, but here's a 5-minute overview in case you're not. So we provide information, coaching, resources, training in the areas of maternal health and early childhood development. We're part of Health Nexus. We're a designated bilingual organization, so we're designated to provide services in French under the provincial legislation. And we're funded in part by the Ontario Ministry of Community, Children and Social Services, and this webinar is funded through that. We have now 6 listserv, and one is specifically for FASD, and it's a new FASD Ontario network, and I do encourage you to sign up for it if you haven't done that. And you can sign up from our website, and there are bulletins also for that. That's part of our FASD Ontario initiative program, and you can sign up right from our main page for all of our listservs. All our resources are available through our website. We have a section of resources for service providers and also one more specifically for parents, and you can direct parents to that directly if you want, because we, as you may know, we're not printing resources anymore. And we have a number of other parent websites with some with videos. Actually, 3 of those 5 are on videos. They're all bilingual. The Children See, Children Learn is on positive discipline. It also has a facilitator guide, so you can provide a workshop for parents on positive discipline for an hour or 2 with the parents you work with. We have Healthy Baby, Healthy Brain that was developed a few years ago, but is maintained and kept up to date with videos, 15 videos in French, 15 in English. Have a Ball Together on physical activity and using the new 24-hour movement guidelines, and it has an activity finder also. If you have different age group, space, no space, equipment, you can find an activity. And we have a website for health before pregnancy, which obviously the message of healthy lifestyle and no alcohol during pregnancy is quite clear, and because people don't necessarily know exactly when they get pregnant, or we don't want to find out when they're pregnant. And then there's the alcohol-free pregnancy website also there. We have some directories, one on breastfeeding services where people can put in their postal code and find the closest breastfeeding service. And we have one on prenatal education, similar thing. We have resources that are all BFI approved for Breastfeeding Resources Ontario, all French, English, and also prenatal education on the key messages to provide to parents. And at the bottom, one of our newer website, FASD Ontario, FASDON.ca, which is a one-stop shop for parents and caregivers of people with FASD. And it's also used by service provider, of course, so you can find services nearby, resources, and we try to add to it. If you see something missing, there's a link to add more resources to it, and we also make sure we stay abreast of news, and it's all on there. And so we try to keep it as comprehensive as possible. I encourage you to visit that website. We have a few online courses, one on supporting healthy weights for people who work with children ages 2 to 11, and one to support breastfeeding, and also two short online courses on supporting physical activity. And this is about it for me. I will just see if there are more questions that have come up. No questions have come up. You must have been so clear, Mary and Karen. I really want to thank you for providing this this webinar. This was excellent, just chock full of information, and we are right on time at 2:30. So thank you very much. You'll get an evaluation link. I really appreciate if you can fill that out, and you'll also have the recording, which you're welcome to share with co-workers. Thank you very much. Have a good day.